So we're going to start with cardiology, just because it's everywhere on the exam. So it's a good topic to be comfortable with. Here's your patient. He comes in with chest pain. What do you want to do? Best first test. That's how a lot of these questions are written. Best first test, best initial treatment, best next step. Let's do an EKG first. So do an EKG. That is your best first test for a patient with chest pain. And what are you looking for on that EKG? ST changes. So we're going to look for ST elevation. Is that the only criteria to diagnose a STEMI? What else is a scary EKG change if it's new? A new left bundle branch block is also scary. So our criteria for a positive EKG are 2 millimeters of ST elevation. Hey, what's up? Or a new left bundle branch block. And if you don't remember what that looks like from your EKG course, that's kind of a wide, flattened QRS. Either of those fulfill criteria for a STEMI. So the ST elevation occurs pretty much immediately. And remember, there are some later changes in the EKG after an MI. T-wave inversion happens a little bit later. And then the Q waves, those are our markers of an old infarct. They last pretty much forever. So also remember, this is prone to come up probably in 1 or 2 questions on your shelf, where in the EKG you're looking for these different types of infarcts. So particularly remember 2-3 and AVF. If you see 2-3 and AVF either described in a question stem or on an EKG printout, that tells you that the right coronary artery was infarcted, and it correlates with an inferior infarct. The rest of those probably a little less likely to show up. Memorize them if you have the brain space, but definitely 2-3 and AVF, remember that that's inferior, and that's the right coronary artery. So treatment of a STEMI, we're going to want to restore blood flow, right? That's the problem. So we want to restore blood flow, and the cath lab is the best. Thrombolytics, when can we give thrombolytics? What's the window where thrombolytics are allowable? The book I read said 6. So thrombolytics, if you catch them within 6 hours, or if you can't get them to a facility where they have a cath lab within a reasonable amount of time, then you can give thrombolytics. Oh, hey, friends. So the contraindications for thrombolytic therapy might also show up on your exam. So some contraindications to thrombolytics, anybody? Yeah, so if you're bleeding, right, thrombolytics is not a good choice. When else? Sure. So if they're anticoagulated, you'd be a little bit more cautious. Ever a hemorrhagic stroke. So ever in the past, if they had a hemorrhagic stroke, you can't give thrombolytics. If they had a recent ischemic stroke, you can't give thrombolytics. And then recent closed head trauma. So if they're, fell off a horse and then had a heart attack, no thrombolytics for them, not allowed. So, also, something that comes up in the Q banks, I don't remember it on my test, but I got like a million questions on it in the Q banks that I did. This case of a right ventricular infarction. So the symptom complex is different than a regular garden variety MI, which is I think why they like to ask about it. And it's a patient who has hypotension and tachycardia, so they're kind of shocky. They do have JVD, but their lungs are clear, so they don't have the crackly, cardiac pulmonary edema, and they also don't have pulsus paradoxus. So it's a kind of a confusing clinical picture unless you're looking for it. So kind of in a nutshell, if you see somebody that looks like they're in shock, they've got JVD, but their lungs are clear, think about a right ventricular infarction. And this is important because the treatment is drastically different between this type of MI and the garden variety type. You don't give nitro, and why is that? If your right ventricle has failed, why is nitro a bad idea? Ooh, I hear whispers. So basically it's because these patients are having a problem with preload, right? Their right ventricle can't pump. They can't get the blood to the lungs and then to the right side of the heart. So really the best treatment here is fluids. They need preload to be added. And nitro is a vasodilator or venodilator, so it's going to further decrease the preload and actually worsen their shock-like picture. So don't know if it'll be on your shelf, but it was in enough of the question banks and review books I figured it was worth a mention. So let's say we did our EKG and there was no ST elevation. What's the next test we want to do for our patient with chest pain? Chest x-ray will probably be done if you're in the ER, right? They like to do those. But if our patient still has chest pain, the EKG was normal, are we totally reassured? What should we do to make sure there's not something cardiac going on? Yeah, now let's do our biomarkers. So cardiac enzymes is the next test. So if you're given a clinical scenario, the EKG's already been done, it's normal. Now we want to order our cardiac enzymes. And if the first set is normal, are we done? Go home? Hit the happy hour? No. So we need at least 3 sets, right? Q8 is typically how it's done at most hospitals. And why is that? Why do we check more than 1 set? This is back to step 1. 4 to 6 hours. Yeah, so most of them won't all be increased if you catch it early enough. So they have different rates of rise depending on the different cardiac enzymes. So we check every 6 to 8 hours to detect a trend. And what I'll point out here is myoglobin, it's the one that rises first. It also drops off first. So if you get a question with a patient who had an MI and they're in the hospital, you're watching them, what's the most sensitive marker for a repeat infarction, a second heart attack? You'll want to look at the myoglobin because CKMB and troponin can both still be elevated from the first heart attack. So a second infarction can be picked up by myoglobin because it's the first to go up and it's the first to go down. You wouldn't expect it to still be elevated a couple days later. Okay, so we treat these NSTEMIs with morphine, oxygen, nitrates, aspirin or clopidogrel, and a beta blocker. That's kind of your classic cocktail for a cardiac patient. And coronary angiography is the best test to schedule for these patients. You want to get this test ordered within 48 hours because that's really how we determine how to proceed from there. So coronary angiography tells us whether or not we need to do some kind of intervention. And what are our options for intervention? Stent or CABG, right? So stent or bypass. And stent is really the standard of treatment unless your patient has certain factors that make CABG the preferred option. And you need to know those. When do you do CABG instead of a PCI? So if you've got left main disease or 3-vessel disease, unless you're a diabetic, and then the threshold is lower. 2-vessel disease in a diabetic, or 3-vessel disease or left main. Yes. So, or if there's greater than 70% occlusion, or if they're just really sick. So you've given them maximum medical treatment, but they're still really symptomatic, still having pain, or after an infarction a few days later, they've got terrible angina where you're suspicious of a reinfarction. Those are all reasons for CABG instead of stenting. So we always send these folks home on aspirin or clopidogrel if they've got a stent. They always need a beta blocker. You need an ACE inhibitor, particularly if they've got some type of left ventricular dysfunction, and we need to give them a statin for prevention of future disease. And then nitrates for their chest pain. Okay, so what if our cardiac enzymes were negative? What are we calling our patient with chest pain? A faker. So pessimistic for so early in your medical career. So let's assume they're not faking, because they rarely are on the shelf exams. You rarely have a faker of a patient on your shelf exams. Real life, maybe. Shelf exam, no. So they've got chest pain. It's terrible. It's crushing, substernal, radiates to their left arm. It's unstable angina. Any new angina is unstable, right? Even if it's just with exertion, if it's new, it's unstable. So the workup for unstable angina, you'll want to schedule an exercise EKG for these folks. And they may ask you what types of medicines you should discontinue before an exercise stress test. Beta blockers and calcium channel blockers would be the answer there. There are some reasons you can't do an EKG stress test, and they like to ask about these. If they've got an old left bundle on their EKG, it makes it very difficult to interpret. If they've got that wide, weird QRS complex, it can make it difficult to assess for any ST changes during exercise. So that would be an indication to do an echo instead of an EKG. Also, if they're on digoxin, that makes interpreting the results of a stress test unreliable, so an echo would be indicated there also. There are a lot of patients, you've probably noticed, that can't perform exercise necessary for an exercise stress test, and in those patients, we chemically stress them. So dobutamine or adenosine are the chemicals we use there. And then MUGA, you may have seen this ordered or heard about it. So a nuclear medicine test that can show the actual perfusion to the heart so you can see very clearly if there's any area of blockage that's leading to ischemia. So what does a positive test look like? It's if they have their chest pain, if they have their characteristic symptoms upon exercise, that's a positive test. If there's ST depression, it's a positive test. Or if their blood pressure drops, the test is also positive. So anytime you have a positive stress test, got to get them to the cath lab, and they need to get some coronary angiography. Okay, so after an MI, what do we worry about in our patients? The most common cause of death in a patient who had a heart attack. Arrhythmia, very good. VFib is the scariest one, right? So what if our post-MI patient has a new systolic murmur 5 to 7 days after their MI? It's a new systolic murmur. Regurg from papillary muscle rupture, absolutely. So the papillary muscles can become ischemic, weaken in the remodeling phase. Remember that from step 1? They can rupture, and that causes a regurg murmur. So it's a new systolic murmur you can hear. What if there's a murmur, but they also have acute hypotension, really sick, basically on death's door? What might have ruptured there? The free wall. So that's a ventricular free wall rupture. If you notice a step up in oxygen concentration between the right atrium and the right ventricle, that's septal rupture. Those are the buzzwords for a septal rupture. And it makes sense, right? If you have more oxygen in the right ventricle than in the right atrium, that means some of the oxygenated blood from the left side is scooting on over there to increase the oxygen content. If you see persistent ST elevation a month later with a systolic mitral regurg murmur, this one's kind of random. Not Dressler, I'm getting there, but you're ahead of me. This is a ventricular wall aneurysm. Not sure why the persistent ST elevation. It may just be because of the thinner wall of the aneurysm inherently doesn't have the blood supply necessary, so you see the ST changes. And the MR murmur is because of the flow in and around the aneurysm outpocketing. So Canon A waves, they love to describe this on physical exam. Do you guys know what Canon A waves are, what you look for? Where do you look for Canon A waves? The jugular, right? You look at the JVP and you just see them bounding. They're Canon, bounding Canon A waves. And what do they tell you? Something's wrong with the heart. Well, I'm not to Dressler yet. Jumping the gun. So what would make blood bound back up to the neck? Sort of. It's a problem with the tricuspid. So what makes the Canon A wave is when the valve between the atria and the ventricle is not opening in conjunction with the cardiac cycle. So, you're supposed to open the valve and blood goes through, but if there's AV dissociation, the valve isn't opening and closing properly, so blood, instead of going forward like it's supposed to, kind of rebounds back and gives the Canon A waves that's visible in the JVP. So Canon A waves, in general, means atrial ventricular dissociation, and in this case, it can be due to third-degree heart block if the AV node is ischemic. So, but in general, Canon A waves mean the atria and the ventricles aren't communicating properly. There's AV dissociation. Now here we go, 5 to 10 weeks later, pleuritic chest pain and a low-grade temperature. Here's your Dressler syndrome. This is thought to be autoimmune, cause of pericarditis, and we treat this with aspirin on NSAIDs. Okay. So now I've got a young, healthy patient, and he's got chest pain. Now we do an EKG, because that's what we always do, right? Best first test for chest pain, and we see this. And I don't know if it's big enough, but can anybody tell me something characteristic about this EKG? Yes, diffuse ST elevation. Please know this EKG, because you might see it. So what does diffuse ST elevation tell you? It tells you pericarditis. So other things they might tell you in the clinical vignette, the chest pain is worse with inspiration or pleuritic. It's better when they lean forward, so position affects the chest pain. And you might hear that rub that you might have heard on step 1, right, when you had to listen to the little murmurs. It was a friction rub. So this is pericarditis. And what do we do for it? NSAIDs, right? We just said that. So, okay, so some other causes of chest pain. If they tell you the pain is reproducible with palpation, think costochondriasis. If it's kind of vague chest pain and they had a viral infection a few weeks or a few months ago and they have a new murmur, myocarditis might be on the differential. If the pain occurs at rest, is worse at night, usually in a lady who also has migraines, think about Prinzmetal's angina. So this is characteristically worse early in the morning. And the test we use to diagnose this type of angina is an ergonovine stimulation test to characterize whether blood vessel spasming might be causing this angina. And calcium channel blockers and nitrates are the treatment of choice here. All right, EKG time. So this first one, anybody want to take a crack at it? What about the P waves? Winky Bach, yes. Do you guys see that YouTube video? Yeah. It's hilarious. If you haven't seen it, you should Google it. So the way they might describe this in a clinical vignette, it's progressive prolongation of the PR interval followed by a dropped beat. And that, as you guys correctly identified, is Winky Bach. Or Mobitz type 1. Mobitz type 1. Okay. So what about this second one? Third degree heart block. So what might you see on physical exam? Canon A waves. Yay. Good. Yeah. So this is third degree heart block. What they might tell you in the clinical vignette, they might tell you they found Canon A waves on physical exam. They also might describe it as a regular P to P interval and a regular R to R interval. But as we can see from the EKG, they're not associated with each other at all. There's not a P before every QRS spaced out regularly. So good. What about the second one or the third one? Not AFib. Not AFib. With AFib, you typically can't see P waves. Good. This is MAT. So what they might tell you in the clinical vignette, if they don't give you this picture, they might describe it as varying PR intervals with 3 or more morphologically distinct P waves in the same lead. And this is good to know because it's bad news in terms of prognosis. This really happens in sick patients with bad pneumonia or otherwise really terrible respiratory disease. So if you see something and it looks kind of weird, you take a look at the P waves because if you can see them, it's probably not AFib. And if you find 3 that are different looking from each other, either inverted or a little sine wave or peaked and not peaked, if you see different P waves, think about MAT, multifocal atrial tachycardia. All right, top one here. What do you notice? Are the QRSs narrow or wide? They're wide, so that helps narrow down your possibilities. So it's wide. Is it fast or slow or regular? It's fast, so it's it's a tachycardia with wide QRS. So yes, it's VTach. So the description they might give you if they didn't show you the picture: 3 or more consecutive beats with a QRS less than 120 at a rate of greater than 120. So I led you astray. That's not a wide complex. And if we had counted the beats, that isn't greater than a block and a half. Sorry about that. I led you astray there. So this is not a wide complex. So it's just ventricular tachycardia. So, okay. So how do we treat VTach? It depends on how the patient looks, right? If the patient's unstable, hypotensive, unconscious, non-responsive, how do we treat them? Shock them, right? And then if they are stable, then we can use medical treatment. We can treat them with lidocaine or amiodarone. So it depends on how the patient looks. Are they stable or unstable? What is their blood pressure doing, etc. So the second strip there, I don't know if you can see it. It's kind of small. Do you notice anything about like this region right here? Yeah, can you convince yourself that that's a delta wave? Maybe it's not the best example I could have found on the internet via Google image, but that is supposed to be a delta wave. So then what does that mean this rhythm is? Yeah, it's WPW. It's Wolff-Parkinson-White. So they might describe it as a short PR interval followed by QRS greater than 120. So this is a wide QRS complex with slurred initial deflection representing early ventricular activation through that bundle of Kent. So super important. How do we treat WPW? The drug of choice was important on step 1. It's important for the medicine shelf. Procainamide, very good. Procainamide is the drug of choice for WPW. Even more importantly, what are you not going to give these patients? What medications are contraindicated in WPW? Anything that slows AV conduction. So beta blockers are contraindicated. Digoxin is contraindicated. The calcium channel blockers that affect the AV node, verapamil and diltiazem are contraindicated. Because remember, anytime we slow conduction through the AV node, that's just allowing more of a signal to go through that squirrely bundle of Kent and screwing it up even worse. So they might give you the picture. I think I got a question about like the medical student or the resident who went into the ER with palpitations, and they gave him a beta blocker, and then he sued the ER doctor 2 years later. You know, what did they give him that facilitated the lawsuit or something like that? So, or why? What was the basis? So remember the pathophysiology here, and that helps you remember what drugs you wouldn't want to give because it would worsen the arrhythmia instead of making it better. Okay, so what about the third one? That's flutter. See the sawtooth? So they might describe it as regular rhythm with a ventricular rate that's between 125 and 150. And the atrial rate, that's even higher, about twice that, 250 or 300. So that's 2 to 1 if we've got that distinction between ventricular and atrial rate. And how do we treat a flutter? Again, if the patient's unstable, it's easy, you shock them. Anytime they have an arrhythmia and they're unstable, you cardiovert. So that's easy. If they're medically stable, here's where beta blockers and digoxin have a role. So it's kind of similar treatment to rate control for atrial fibrillation. A-flutter and AFib are treated very similarly. Then that last one, would you like that to be your EKG? No. So what's that? Yes, that's torsades. So they might describe it as a prolonged QT interval leading to undulating rotation of the QRS complex around the baseline. And in the clinical vignette, look for some kind of electrolyte abnormality. Low potassium and low magnesium can predispose a patient to this. And then extending into the psych realm, a tricyclic overdose can also cause torsades. Okay, so what's this first one? Slow, fast, or normal? That's fast, so it's a tachycardia. Take a guess. Ectopic atrial. This is supraventricular tachycardia. This is SVT. So they might describe it. I think it's kind of hard to pick it out based on the EKG alone. The description makes it a little easier. If they told you it was regular rhythm and the rate was somewhere between 150 and 220, also the clinical symptoms help you here. This is like the 27, 28-year-old guy or girl who just suddenly has these terrible palpitations and then they suddenly go away. So there's a sudden onset and offset that's also pretty characteristic of SVT. And what's the first line treatment for SVT? Very first thing you do for them when they walk in the door. Yes, carotid massage, good, because they're going to try to trip you up by giving you a bunch of drugs to choose from. But first line treatment is actually non-pharmacologic. Carotid sinus massage. For the kids, we shove their face in ice water. I guess you could do that for adults too. Non-meds first, and then your medications. This is where adenosine comes into play. So with the tachycardias, adenosine might be the right answer if they're looking for a medication. So the second one here, there's kind of a lot going on. What I want you to look at is this business. What's that? That's a T wave. That's peaked. That's a peak T wave. So what does that make us think of? Hyperkalemia. Good. The medicine folks love hyperkalemia, don't they? So in the clinical vignette, they might tell you this is a renal patient who missed a bunch of dialysis appointments. Could be crush injury because the potassium is released from the damaged cells. Burn victim, blah, blah, blah. The T waves are peaked. The QRS is wide. The QT interval is short, and the PR interval is long. So hopefully they give you peaked T waves. I had a couple questions on my QBank where they gave you those other EKG findings described, like the widened QRS and the short QT. So if you want to be safe, know them all. And I missed this one like 3 or 4 times on my QBank, this third one right here. WTF is that? Right? What did you notice about this EKG? So the baseline is kind of undulating, and that helps with the name. It's not MIT because we don't really see morphologically distinct P waves. It's kind of hard to see them because it's such low voltage. So the 2 hallmarks here is there's alternate beat variation in direction, so it's kind of undulating, and then it's very low volume. So the clinical picture helps, right? You also notice pulsus paradoxus, hypotension, and distant heart sounds, and JVD. What does that picture make you think of? That's tamponade. So this is the EKG finding of tamponade. It's called electrical alternans. Electrical alternans. So it's kind of alternating. That's where the alternans comes from. And it makes sense if we've got tamponade, right? That blood is filling up the sac, so it's dampening the voltage. That's why it's so short, why it's such a low voltage EKG tracing. All right, number 4. There you go. Can't really see P waves there, right? Just kind of some squiggly business along the baseline. So this is AFib. They might describe it as an undulating baseline. Can't see the P waves. It's irregularly irregular. And the clinical vignette, the patient might be hyperthyroid. That's pretty common. Or somebody taking too much of their synthroid. Might be some old dude with sudden palpitations, shortness of breath, or somebody with CHF who has valve disease, right? Because if your mitral valve is really bad, that leads to dilation of the left atria, which predisposes to atrial fibrillation. So rate control or rhythm control, which is better? Yeah, neither of them are better, so we do rate control, right? Rhythm control hasn't been proven to be any better than rate control, so we use drugs to control the rate of atrial fibrillation in our first line of treatment. So how do we do that? What meds? Yeah, beta blocker or DIG. Yeah, those are kind of the mainstays. Okay. So any questions about EKGs? I tried to pull out all the ones that I got questions on, either in real life or in QBank land. All right. So now let's go to murmurs, the other common question type in the cardiology section. So I've got a systolic murmur. It's crescendo, decrescendo. It's louder when they squat, softer when they valsalva, and you might see parvus et tardus in their pulses when you're palpating aortic pulse or peripheral pulse. Aortic stenosis, very good. So some things that might cause aortic stenosis. So old, right, calcific degeneration, I think is what it's called, of the valve. So it just could be old. Yeah, or if it's congenitally, the aortic valve is bicuspid, that might predispose someone to get it a little bit younger. More importantly, how do we treat it? Yeah, so do we shove a balloon in there and open up the stenotic valve, or do we just replace the whole enchilada? We replace it. So valve replacement is the standard of treatment. You only would do balloon valvuloplasty if you were just stabilizing the patient so you could get them to somewhere that could perform the operation. So, okay. So what about this second dude? It's also a systolic murmur, but it's louder with valsalva, softer with squatting, and hand grip. This might be a young patient in for their sports physical. Hypertrophic obstructive cardiomyopathy. So this is HOCM. The hallmarks to remember here is it'll typically be a younger patient. That'll help you, but also louder with valsalva because the systolic ejection murmur of aortic stenosis is softer with valsalva because valsalva decreases preload, right? So that makes less blood go across the stenosed valve. So that'll improve an aortic stenosis murmur, but it'll worsen a HOCM murmur. So that's kind of the differentiating factor that I remembered. Now where it becomes tricky is in this third fella, late systolic murmur with a click. And it's louder with valsalva, just like HOCM, but softer with squatting. The key is the click. This also might be a younger patient. Yeah, so this is mitral valve prolapse, MVP. So this patient clinically might present with palpitations, some syncope, and then the murmur actually can be pretty loud. And our last systolic murmur, this one radiates to the axilla, and it's different from the other ones in that it's not an ejection murmur, it's holosystolic. Yes, MR. This is mitral regurgitation. Good. Okay, so another holosystolic murmur, but this is in kiddos. Most common congenital heart defect. VSD. Yeah, you thought there wouldn't be any peds on your test, but there might be. And then a continuous machine-like murmur. Remember this from step 1? PDA. Wide, fixed, and split S2. That's an ASD. Those are kind of just the key buzzwords. And then a rumbling diastolic murmur with an opening snap. If you did an echo, you might see left atrial enlargement, and it predisposes to AFib. Mitral stenosis, good. And blowing diastolic murmur with a widened pulse pressure. And this is the one with like the water hammer pulse, all those dead guys that have their, you know. I don't remember them anymore because I already took my steps, but you guys know. What's this one? Yeah, so this is aortic regurgitation. Mitral stenosis and aortic regurg are the two most important diastolic murmurs, at least in the adult population. So really when a patient comes in, they're not coming in, you're reading about them in the clinical vignette, they can have shortness of breath for cardiac or pulmonary reasons, right? So if you suspect a pulmonary embolus, that can cause shortness of breath, and that's a really scary cause of shortness of breath. You want to give heparin right away. Before you do your workup, heparin first is always the right answer if you really suspect a pulmonary embolus. You'll always want to check the O2 stat. If the pulse ox isn't given in the clinical vignette and the option to get one is there, that's usually a good idea. Anytime you suspect pneumonia, like if there are those characteristic breath sounds, egophony, all that business, you want to get a chest x-ray. Anytime somebody with congestive heart failure has a murmur, an echo is the right study to get and compare it to an old echo to see if it's progressing. And for acute pulmonary edema, I got this question a lot in the Q banks. The trifecta of medications are nitrates, Lasix, and morphine. Any patient who kind of looks like they have CHF, but they're young, they're not our old person who we expect to have it, think about myocarditis. This is like the kind of random cardiac problem that mimics a lot of other things and has a confusing constellation of symptoms. So if they're young, if they had the flu a couple weeks ago, and they either have shortness of breath upon exertion or need 3 pillows at night, think about Coxsackie-B or some other viral form of myocarditis. And then also in a young patient, a cause of shortness of breath might be primary pulmonary hypertension. And this will cause cardiomegaly on a chest x-ray, and a right heart cath is the next study to order because it can really definitively tell you whether it is primary pulmonary hypertension or congestive heart failure. And how is that? What pressure are you looking for on right heart cath? Good. See my high-tech drawing I made on paint? So this is your heart over here. These are your lungs. And if the problem is your heart, right, the problem is your heart, the congestive heart failure, your ventricle can't contract, you're not propelling blood forward, it's going to back up here, right, into the left atrium. And pulmonary capillary wedge pressure we use as a surrogate for left atrial pressure. So in CHF, this is going to be high. Whereas in your primary pulmonary hypertension, the problem is here. There's increased resistance in the pulmonary vessels, so the blood doesn't even get to the left atrium. It backs up into the pulmonary artery. So in CHF, we have high pulmonary capillary wedge pressure. In primary pulmonary hypertension, pulmonary capillary wedge pressure is normal. So that's really the key pressure to look at. They often give you a bunch of different pressures in these chambers and vessels. You really don't need them if that's the determination you're trying to make. All right. So if you did medicine at any of the sites that we do medicine at here, you've seen a lot of CHF and have seen how to manage it. So remember that it's divided into systolic and diastolic, depending on whether the problem is propelling blood forward or relaxing the heart in diastole. And the things that I saw questions asked about, are there reversible causes of either? So alcoholic dilated cardiomyopathy is reversible if they stop drinking, which they never do. And then hemochromatosis causes a restrictive cardiomyopathy, which is diastolic dysfunction, and that's also reversible with phlebotomy. So if you reduce the overall iron overload in the body, you can get some of your ejection fraction back, which is nice. So treatment of CHF, remember the medications that improve survival. Remember ACE inhibitors have been shown to improve survival, and beta blockers as well, for the same reason. They prevent remodeling in the ventricle. ACE inhibitors because they block aldosterone from remodeling, and beta blockers because they prevent epinephrine and norepinephrine from remodeling. Spironolactone, this is kind of newer. It's improved survival only if the heart failure is really bad, class 3 or 4. And then digoxin is usually the detractor answer. It does not improve survival, but it does help symptoms. So we give it to patients, it makes them feel better. They're less likely to be hospitalized with an exacerbation.